I'd like to start out by thanking the organizers for inviting me virtually and saying that I'm really honored, but I'm also a little bit sad that I can't be with old friends and new friends and physically share the day with you, but perhaps in the future, and we'll do the best we can to learn virtually. I have one disclosure, and that is that I have a research grant from UCB, and I will be talking about a product they make. It's a trial. I'm not going to be suggesting off-label use. Here are some references, and you'll have the recording, so you can go back to look at them. They're referred to on some of my slides. So I'd like to start out with a painting by Gustav Klimt that's in the Museum of Modern Art in New York. And when I saw the painting, it made me think of what it must be like to be pregnant or contemplating pregnancy, but really to be pregnant and have lupus or antiphospholipid syndrome. And in this painting, you see a pregnant woman. She bows her head and closes her eyes as if praying for the safety of her unborn child. And the head of death here, it lurks ominously as a sign of the danger she faces. And at her feet, you see three women, solemn, heads bowed, underscoring the potential for a tragic outcome. Women who are pregnant with lupus have higher rates of preeclampsia, fetal and neonatal death, and fetal growth restriction. And the challenge we have as physicians caring for them is identifying the women who are destined for these complications. We can't counsel them if we can't identify which ones are going to get into trouble. And finally, treatments to prevent poor pregnancy outcomes require an understanding of the mechanisms of injury. So today I'll talk to you about the pathogenesis of pregnancy complications in lupus and APS, the predictors of risk, and the potential targets for treatment. To start, let's look at the trends in pregnancy outcome over the past 18 years. These data were recently published, and they mined the US National Inpatient Sample Database. They reflect nearly 100,000 pregnant women with lupus and 78 million pregnant women who don't have lupus. The red line is lupus, the blue is non-lupus, and you can see that in-hospital mortality of lupus patients is going down dramatically and converging with that of patients who don't have lupus. Fetal mortality is also improving, but there's still a substantial difference between children born of women with lupus than healthy controls. It's more than a twofold difference, closer to the threefold difference. And then if you look at preeclampsia or eclampsia, the story is a lot worse. It's increasing in lupus, it's actually increasing in healthy controls, and there's no evidence of converging. Lupus patients still have a dramatically different likelihood of having preeclampsia. So let me tell you a little about preeclampsia. It's a pregnancy-specific disorder that's defined by the appearance of hypertension and proteinuria, usually after 20 weeks gestation. So in the beginning of pregnancy, the abnormalities that are occurring in a woman who will get preeclampsia are completely silent. Neither the patient nor her physician sees that there's a problem going on. And what the problem is from the standpoint of physiology is the spiral arteries. This is a spiral artery. This is the placental side. This is the maternal side. The spiral arteries don't remodel. So in a normal pregnancy, very early on, the spiral arteries become dilated, flaccid blood vessels, leading to perfusion of the placental intervillous space. In preeclampsia, that doesn't happen. So why doesn't it happen? In a normal pregnancy, the lining, the endothelial cells that line the the spiral artery, actually come from the placenta. They come from trophoblasts, and they invade the artery and replace the endothelium, and as a consequence, the smooth muscle disappears, and you have almost a vein where you started out with an artery. In preeclampsia, that doesn't happen. You still have a lot of smooth muscle, you have maternal endothelium, so you have a much higher resistant, lower flow perfusion to the placenta. And this cartoon also shows in early pregnancy, here are extravillous trophoblasts from the placenta invading the maternal spiral arteries. Later in pregnancy, there's even more invasion, and you can see these big pools of blood that are perfusing the placenta and the developing fetus. But in preeclampsia, or babies that will be born small for gestational age, there's much less invasion, there's less perfusion. And in severe preeclampsia or stillbirth, there's almost none. So there's extreme hypoxia and poor perfusion. And as a consequence of this poor perfusion, the placenta releases factors that are toxic to the maternal vasculature. The hypoxic placenta is stressed out. So this cartoon shows a blood vessel. The endothelial cells on the blood vessel express receptors called VEGF-R1 and VEGF-R2, which stands for vascular endothelial cell growth factor receptor 1 and 2. And in certain vascular beds, particularly the glomeruli and some in the liver and the central nervous system, these receptors must be bound in order to signal. And the receptors are bound by placental growth factor or VEGF. And that signaling, ligand receptor signaling, is essential for normal homeostasis and normal endothelial function. Placentas make small amounts of a splice variant of this blue guy, VEGF-R1, that can bind the ligand, you can see, but it doesn't signal. It's almost like a soluble TNF receptor that we give for the therapy of rheumatoid arthritis. It binds TNF, but it doesn't signal. And what happens in preeclampsia is the stressed hypoxic placenta that's underperfused makes lots and lots of this S-split. The S-split binds to placental growth factor and VEGF. And then the endothelial cell perceives a VEGF placental growth factor deficiency state, and the cells start to die. They get swollen and they die. And as a consequence of the cells dying, the organs that are perfused by those cells become dysfunctional. And we know this is the case because when you treat cancer patients with antibodies to VEGF and you similarly induce a VEGF deficiency state in certain vascular beds that need VEGF signaling for homeostasis, you get phenotypes similar to preeclampsia. You get hypertension and proteinuria. So you can see that in a normal pregnancy, there's an excess of the growth factor, placental growth factor or VEGF. And in preeclampsia in the blood, there's an excess of S-split, the anti-angiogenic factor. And clinically, the maternal systemic response to poor placental blood flow is hypertension because of injury to the glomerular bed, proteinuria, and other end organ manifestations attributed to this widespread vascular dysfunction mediated by the placental secretion of these anti-angiogenic factors like S-split. Now, the clinical manifestations that we perceive as physicians or even as patients after 20 weeks are these on the cartoon, or actually the photograph of the pregnant woman that Picasso did. So in lupus patients, as I showed you from the epidemiologic data, there's an increased incidence of preeclampsia, hypertensive disease of pregnancy, placental insufficiency, growth restriction, and pregnancy loss. And from a clinical standpoint, the presence of antiphospholipid antibodies in a lupus patient is the strongest predictor of pregnancy complications. And in fact, even in non-lupus patients, we all know that antiphospholipid antibodies are associated with pregnancy complications. So to explore mechanisms by which antiphospholipid antibodies can cause abnormalities in pregnancy, We established a mouse model. Mouse pregnancy is 21 days. If you inject a pregnant mouse with IgG from patients and from healthy controls, you can see whether or not the IgG causes a pregnancy phenotype in a mouse. So when you inject a mouse with antibodies from a healthy individual, polyclonal IgG, you have normal formation of pups. This little cartoon shows what looks like a pearl necklace, and that's really what the uterus of a mouse looks like. Each of these sacs would contain a pup. If you treat a mouse with IgG from a lupus patient with antiphospholipid antibodies or primary APL patients, you can see that their resorption of many of the fetuses and the ones that would have been viable are smaller than the healthy controls. So we recapitulated the human phenotype, which is pregnancy loss or growth restriction. And then using knockout mice and a series of monoclonal antibodies and small peptides, we were able to dissect the key mediators, the inflammatory mediators that cause this damage and rescue pregnancy in APL-treated mice. And with these inhibitors, and I'll go over the pathway we described, we were able to prevent APL-associated growth restriction and fetal death. So what did we discover? We discovered that antiphospholipid antibodies deposit on the placental cell surface, and they activate complement. C3 is required, C3b deposits on the maternal fetal interface. We can see that histologically. There's generation of the C5 convertase and creation of the C5a anaflatoxin. C5b through 9 deposits on the cell surface. The anaflatoxin recruits and activates inflammatory cells, neutrophils initially, and then monocytes. If you block C5a, you rescue the phenotype. If you deplete neutrophils, you rescue the phenotype. The neutrophils release cytokines, and there are many of them we'll talk about in a moment, and that leads to abnormal placental development and growth restriction, fetal death, and in some situations, preeclampsia in APL-treated mice. Mice that are deficient in the C5a receptor or treated with antibodies or peptides that block C5a receptor interactions are completely protected, arguing that complement is a critical and is both necessary and sufficient to cause APL-induced abnormalities in mice treated in mouse pregnancy. Is there evidence for complement activation in human pregnancy, or are we just kind of studying a mouse model that has minimal relevance? And we're not. If you look at the maternal fetal interface of placentas from women with lupus or APS, or women with preeclampsia, actually, who don't have autoimmunity, there's evidence of C4D, which is sort of a footprint of or fingerprint of the classic pathway activation. If you look in the blood of women with APL or women who are destined to preeclampsia without autoimmunity, you have increased levels of the activation fragment of factor B, showing that alternative pathway contributes. And in our mouse models, in fact, if you block the alternative pathway, you rescue pregnancy complications. And lastly, if you look at the complement regulatory proteins that prevent this accelerated amplifying pathway locally, if you have hypomorphic regulators, you're more likely to get preeclampsia if you have lupus or APL, or even if you don't. In addition, we were challenged by the naysayers who said complement's not relevant. APL is a thrombophilic disease, and we know that, and heparin seems to be effective, so what are you talking about? You're studying mice, not people. And we showed that heparin actually inhibits the cleavage of C3 in vitro, and that heparin rescues the phenotype to some extent in the APL mice, and that if you use Hiruidin or other non-heparin anticoagulants, you anticoagulate the mouse, but you don't rescue the pregnancy. So it might be that the effectiveness, though they're not terribly effective, but the effectiveness of heparins in preventing obstetric complications in women with APS may in fact be due to complement inhibitory effects rather than to anticoagulant activities. But to move forward to think about a potential realistic target to prevent maternal fetal inflammation, because inflammation is this key pathway that we're studying and that we know is important in pregnancy loss and growth restriction. We wanted to target something that there already are drugs for in our armamentarium. And that was the question of what are the cytokines? What are the cytokines that are key mediators locally that may be released by the recruited inflammatory cells? And of course, the first one to come to mind if you're a rheumatologist is TNF. And when we treated mice either with TNF inhibitors or studied mice that were deficient in TNF or TNF receptors, we were totally able to correct the phenotype, arguing that we might have a useful therapeutic for APS-induced pregnancy complications, fetal loss, and growth restriction. But I started out talking to you about preeclampsia, and you do get some element of preeclampsia in the APL mouse, but it's not really robust. And so we looked to a mouse model of preeclampsia. So this is a non-autoimmune mouse called the BPH5 mouse. So BPH is blood pressure high. It's the 5th strain of this kind of blood pressure high mouse. And this mouse has mild hypertension. The BPH2 has tremendous hypertension. And in this mildly hypertensive mouse, when you do brother-sister matings, the mouse who's pregnant starts to look like a preeclamptic woman. Her blood pressure goes up quite a bit. She develops proteinuria. There's an angiogenic imbalance, like I told you about. There's a deficiency in VEGF. There's placental dysfunction. The developing placenta doesn't invade properly and is hypoperfused, very much like what you see in a pregnant woman with lupus or APS or even preeclampsia for another reason. And there's a substantial fetal loss and growth restriction. So we had a preeclamptic mouse with no autoimmunity, and the question was whether or not TNF blockade would rescue or prevent preeclampsia in this mouse. And in fact, it did. When we treated the mouse with a TNF blocker, the placental dysfunction was prevented. The spiral arteries, which I showed you in the cartoon, completely remodeled. So they became venous-like, whereas in the wild-type untreated mouse, the spiral arteries didn't remodel. The angiogenic imbalance was corrected, and fetal loss and growth restriction was corrected. So here we had evidence that TNF blockade prevented preeclampsia in another mouse model. So we had a therapeutic, but I started out asking, how do you predict risk? Because we know not every lupus patient has a complication, and how do you intervene in women who really don't need an intervention? How can we figure out who is at risk? And we were fortunate to convince the NIH that this was a meaningful question that they should invest in. And they funded it was NIAMS funded the PROMISSE study, which is predictors of pregnancy outcome biomarkers in antiphospholipid syndrome and systemic lupus erythematosus. It was a prospective, multi-center, multiracial, multi-ethnic observational study to look for markers to identify those at risk. It ran for 11 years. We recruited 755 patients. They were all seen every month, beginning at less than 12 weeks gestation. They were divided up as to having lupus, having APL antibodies. They didn't have to have APS, or having both. And then we recruited about 200 healthy controls. All of the lupus patients had inactive, stable, mild disease. They couldn't have proteinuria. If they had hypertension, they had to be well controlled on an antihypertensive. They couldn't be on high doses of prednisone. And we have freezers where we're paying an awful lot of money for the real estate that contain a 250,000 samples in New York. So what did we learn from PROMISSE? First, You can see we enrolled nearly 500 patients with lupus and or APS and 200 healthy controls. So the first question we addressed is, do patients who at conception, when they're enrolled, have flares in pregnancy? And about 20% of these 500 patients, it was actually 400 lupus patients, but some had just APL antibodies. About 20% of the lupus patients had mild flares, and almost none of them needed any treatment whatsoever. And 6% had severe flares. Younger age, low C4, and a higher PGA at baseline, so baselines before 12 weeks, were independently associated with flares in the second or third trimester. Then how about postpartum? In RA, they may be postpartum flares. What happens in lupus? In lupus patients postpartum, the flare frequency was quite similar to those that during pregnancy. About in the 28% had mild and moderate flares. Again, these didn't require treatment, and only 2% had severe flares. So how about renal involvement? Patients, when I was training, were told, don't get pregnant, you'll have renal failure, you'll die. And I want to underscore that we had a very mixed racial and ethnic population of lupus patients in PROMISSE. So we were looking at patients who potentially are at increased risk for renal disease. And what we found was of 255 patients of the nearly 400 who did not have a history of renal involvement, 2% of them developed de novo renal involvement. And of those with a history of renal disease, 118 had true renal disease documented prior to their pregnancy. 11% of them had renal flares. So if you look at these 4 patients plus these 13 patients, you have 17 with renal flares out of 400 patients, and nearly all of them, after postpartum, their renal function went back to normal. Their creatinines were increased by maybe 0.2, and only 2 patients had a creatinine greater than 1.4 a few months after pregnancy. And of course, past history and low C4, past history of renal disease and low C4 were independently associated with a higher risk of developing active nephritis. So I think these data show that maternal outcomes are quite good from the standpoint of lupus if, when the patient becomes pregnant, their disease is stably mild or inactive. And I think that's a key point in counseling our patients and timing pregnancy. But how about the pregnancy outcome? What happened to the deliveries? What happened to the pregnancy, the fetal side, not the maternal side? And you can see here in the red box, 21% of the patients had an adverse pregnancy outcome that includes preterm delivery indicated by placental insufficiency before 34 weeks. It includes, for preeclampsia, it includes growth restriction, fetal or neonatal death. The growth restriction was less than the 5th percentile. And the healthy controls, they were very healthy. They were not PROMISSE. They'd had other pregnancies before. The adverse outcome rate was 3%. So what kinds of adverse outcomes did the patients have? These 19% of patients who had adverse outcomes, 4% fetal death, 1% neonatal death associated with growth restriction or preterm delivery. 8% had indicated preterm delivery because of placental insufficiency, and that would be preeclampsia or severely poor growth in utero. And 10% had small for gestational age babies. And that's the less than the 5th percentile, so it's twice as much as you'd expect. So what features were unique to those 19% of patients? What features were independently predictive of an adverse outcome as defined by PROMISSE? And if you were white, you were protected. You had half the likelihood of an adverse outcome. The other risk factors were having been on a hypertensive. So these are women who were on antihypertensives, who had high blood pressure, who were on antihypertensives when they enrolled in PROMISSE, and I think that speaks to some differences in their vasculature. All of them had well-controlled blood pressure during pregnancy and certainly at baseline, or else we couldn't have enrolled them. And having a lupus anticoagulant was the strongest risk factor. Having an anticardiolipin or a beta-2 were not, at greater than 40, were not independent predictors of adverse outcome. It was the lupus anticoagulant specifically. So what about the ethnic and racial distribution of the patients, and how do we understand why that is associated with risk? So you can see that the PGAs were slightly higher in the women of color, but in general, the mean PGAs were about 0.9, and you can see that a small percentage really had higher PGAs. And again, these patients were on low doses of steroid. They had to have inactive disease in enrollment. Their lab tests had to be really stable. So the PGAs of greater than 1 were probably 1 point something. These were not sick patients. So I don't think that can be attributed exclusively. The other issue we thought about is missed visits. Maybe they couldn't get to see the study team on a monthly basis, but you can see, I mean, I was actually surprised. The missed visit frequency was pretty low all across, and very few patients missed more than two or more than 3 visits, and it was pretty even across the different ethnic and racial distributions. But as you might expect, the socioeconomic characteristics of the patients or the communities they lived in, looking at census data, was dramatically different. So if you look at the frequency of adverse pregnancy outcome by race and ethnicity, without APL, these are the lupus patients, about 11% of the whites had adverse outcome, and about twice as many the women of color. If you look at patients who had APL, I told you APL was a high risk factor, 30% of the whites had adverse outcome. But these numbers are small, not unexpectedly, because APL is less common in women of color. But you can see here that among even the few of them, the frequency of adverse outcome is twice as much. So what are the independent variables? What models can we look at to attribute this disparity in outcome? So first, we adjusted for the clinical variables, the PGA, being on an antihypertensive medicine, missing visits. And you can see that when we adjusted for that, you didn't really decrease the difference between whites and non-whites who had APL, and you minimally decreased the difference of whites, which is the reference, and non-whites. But when you adjusted for personal education, we asked the patients their education, or community income or education, the difference between whites and non-whites who did not have APL became insignificant. APL, since it is such a risk factor, such a strong risk factor, when we made that adjustment, there was really no difference. So one could argue that in African American women, because we had a large number of them and the greatest power to address this, socioeconomic factors are the key contributors to disparities in health outcomes if they don't have APL, despite monthly care from the same experts and the same kind of care, whereas other factors contribute to the disparities in lupus patients with APL. So I don't know how the socioeconomic factors contribute, but I think it's a very important question we have to continue to pursue. And certainly disparities in pregnancy outcomes occur even in women without lupus. So if we go back to the predictors of poor pregnancy outcome, which would be being non-white, being on an antihypertensive, or having a lupus anticoagulant, if we look at the women, the 50 women who had either a lupus anticoagulant positive or were LIC negative but were non-white and having to take antihypertensive medications during pregnancy, there was a 58% adverse outcome rate and 22% fetal or neonatal death. These are huge numbers. However, in women who had none of the baseline factors that I show you on the table on the previous slide, the adverse outcome rate was 7.6%, which is really identical to that you'd see in an all-comers pregnant women's clinic. So we can risk stratify based on clinical factors in the first trimester. How about biomarkers? I talked about the anti-angiogenic factors, and in most studies of non-autoimmune preeclamptic women, they're used to predict preeclampsia or when it will occur. If a patient comes to the ER and has mild hypertension, you can decide whether to admit her or not based on this ratio. It's not FDA approved yet, it's still a research test, but in Europe they use it. So if the S-split is really high, you might you'll want to admit her because there's impending preeclampsia, and the higher the S-split, the more likely it is that the patient will need delivery, which is the only treatment of preeclampsia. It's delivery. So you remove the placenta, which is secreting these angiogenic factors, which are toxic to the maternal endothelium. So what about in lupus patients? We stratified the lupus patients, well, we stratified the PROMISSE population, healthy controls in blue, nearly 200, lupus and APL patients who had good outcomes of pregnancy, 384, and then we stratified the adverse outcomes to those that we thought were most severe, so delivery less than 34 weeks, and in these patients, the mean delivery was about 28 weeks. So these were really severe bad outcomes, fetal or neonatal death, or indicated delivery because of placental insufficiency, so indicated rather than preeclampsia, of less than 30 weeks. So that meant that the fetus was really doing poorly. And then the SLE and APL patients with moderate outcomes were the other PROMISSE outcomes, PE more than 34 weeks. Indicated delivery 30 to 36 weeks, and growth restriction, which is generally the babies do fine. And if you look at the S-split, this anti-angiogenic factor, in those with severe outcomes, as early as 12 to 15 weeks, there's significant differences. The rate of rise is dramatically higher, the slope and the values are higher. The women with lupus who have moderate outcomes, it's really not as dramatic or as useful a predictor. If we look at the placental growth factor that balances out the S-split, placental growth factor goes up in normal pregnancy as the placenta grows, those placental growth factors made by placentas, but you can see in the women with the poorly perfused placentas, the placental growth factor doesn't go up as high. The statistical differences are evident early on, and the rate of rise is lower. But most dramatically, if you look at the ratio between the anti-angiogenic factor and the pro-angiogenic factor, you can see that it's a very important difference. It's a statistical difference very early on in pregnancy. It precedes the outcome. This is going on at a time when the pregnancy looks like it's okay clinically. And if you take patients who have S-split in the highest quartile and placental growth factor in the lowest quartile, so we're not doing a cutoff, we're looking at quartiles, and we're looking over here at 16 to 19 weeks. And you add, so these women had a 31 times greater likelihood of having a severe adverse outcome. But if you add that to a lupus anticoagulant or a history of high blood pressure, you have a 94% chance of one of these severe adverse outcomes. So combining clinical with biomarker readouts really allows you to stratify patients as to their likelihood of having a severe adverse outcome. So I don't have time to go over the other biomarkers we looked at. Of course, the interest in complement is where this whole story started, and you can measure complement activation products early in pregnancy, and they're elevated in women destined for severe adverse outcomes, but the predictive value is not as strong as the anti-angiogenic factors. The assays are less robust, and the collection of samples is very demanding. The way in which you process them. but alternative pathway is quite important, which speaks to a potential therapeutic intervention. And we also did longitudinal profiling of the blood transcriptomes, and we found really interesting suppression of gene expression of lupus-associated gene clusters of type 1 interferons and plasma cells in normal pregnancy. They weren't as high as in lupus patients, but in all pregnancies that will work out all right, you have suppression of these pathways. Whereas in patients who will have adverse outcomes, lupus patients, you don't have adequate suppression of type 1 interferons and plasma cells, arguing that these could be mechanistically important. So based on the mouse studies and the PROMISSE studies that lets us risk stratify, we can actually translate the basic science studies to apply them to patients. And the translation we chose to make was, we hypothesized that TNF blockade early in pregnancy would significantly decrease the rate of fetal death and preterm delivery due to placental insufficiency or preeclampsia in women with antiphospholipid syndrome, and I'll tell you why we changed it from APL to antiphospholipid syndrome, who had a lupus anticoagulant, the strongest predictor of adverse outcome. So this study is called the IMPACT trial, improved pregnancy outcome in APS with certolizumab therapy, where Branch is the co-PI and it's funded by NIAMS. We are testing the hypothesis I described, whether TNF blockade added to a regimen of heparin and low-dose aspirin during pregnancy reduces the rate of fetal death and or preterm delivery due to preeclampsia or placental insufficiency in these high-risk pregnancies. It's an open-label, single-stage phase 2 trial using certolizumab, and the pregnancy outcomes are going to be compared to those of women with APS who have repeatedly positive lupus anticoagulant. So how did we power the study, and why did we identify this specific subgroup for enrollment in the IMPACT trial? And it shows you how the observational studies can really inform subsequent interventional studies. So if we looked at severe adverse outcomes, fetal death, preeclampsia less than 34 weeks, placental insufficiency requiring delivery less than 34 weeks, these were the outcomes we were going to look at in IMPACT, and these were outcomes we had data on in PROMISSE. And if we look at women with APS, because in work I didn't have time to tell you about, having true APS, thrombosis or APS criteria for pregnancy complications also increased your likelihood of a subsequent severe outcome. So if we took patients with true APS and with a lupus anticoagulant that was persistently positive, 44% of them had at least one of these severe adverse outcomes. And they were severe. If you look at the mean gestational age, the ones who died were delivered at 21 weeks. If you look at, we said less than 34 weeks, the mean gestational age of delivery was 27 weeks. Indicated delivery, so this is a baby not developing well in utero. The mean delivery was 24, so they're delivering really early babies because they may not survive. So we're talking about a severe phenotype, and 44% of patients had that. So in our power calculation, we said, okay, if our intervention is ineffective, the likelihood, the outcome is going to be patients open labels, single arm, that 40% of patients will have one of these outcomes. If our intervention decreases the rate of that outcome by 50%, so 20% of the patients have that outcome, with an alpha of 0.05 and a power of 90%, we'll need 45 interpretable patients to be enrolled. So our plan was to enroll 50 in case there are dropouts. So as you saw from PROMISSE, there were of the 735 patients, I think there were 6 dropouts, lost to follow-up. So what are the inclusion criteria? And I'm giving you a lot of detail because this is an announcement. Hopefully you can refer patients to us. Patients have to be enrolled and screened less than 8 weeks gestation. We actually often talk to patients after they've had a severe outcome, and they will tell us the next time they become pregnant. They need clinical manifestations of meeting criteria in the past of true APS, obstetric or thrombotic. They need a positive lupus anticoagulant on 2 or more occasions greater than 12 weeks apart, and one of them has to be within the last 18 months. Some of these people are on anticoagulation, so it's hard to repeat the lupus anticoagulant. We'll take it if it was positive twice, and one of the times was less than 18 months ago. They have to be less than 40 years old. They can't be anemic and obviously have to give informed consent, and we review medical records to be sure they meet inclusion criteria. The adverse outcome is a composite of 2 pieces of evidence of poor placentation, fetal death greater than 10 weeks, so not early losses, and severe preeclampsia or placental insufficiency less than 34 weeks. The treatment is certolizumab pegol. It's an anti-TNF alpha monoclonal antibody, half-life of 14 days. It preferentially penetrates inflamed tissues and is approved for a wide range of rheumatic disease, IBD, and psoriasis. It does not cross the placenta. It lacks an FC region. So it doesn't get into the baby's circulation, and that has been shown. All patients will get the certolizumab at the same doses as for RA and Crohn's. The first dose is at 8 weeks and 6 days because we're targeting the abnormal placentation, which we saw in the mouse, and we know that angiogenic dysregulation occurs as early as 12 to 15 weeks. So we have to prevent the inflammatory injury and hopefully allow remodeling of spiral arteries very, very early. So we've got to get these patients really early. We stop the drug at 28 weeks because if you've made it to 28 weeks and the drug has a half-life of 14 days, it'll still be around at 30 weeks. And 30 weeks is a time when deliveries are generally okay or can be. But certainly if you've made it through 30 weeks with no evidence of placental insufficiency, it's the placenta's developed well enough, so I don't think it's an issue that from 30 weeks on, you'll develop substantial abnormalities in placental perfusion. So what's happened? The study's been around for over 3 years. Actually, COVID had a little bit of an impact, but we were enrolling during COVID. We were allowed to enroll. We've enrolled 26 patients. Only 4 have declined, and 2 of those 4 were during COVID. We excluded a number based on our inclusion criteria. Of the 26 patients, 24 have completed their pregnancies. 2 are still pregnant. 1 patient discontinued early on because she had a lethal genetic mutation, and the baby died. So this is not an interpretable pregnancy. Of the 23 others, 20 had uncomplicated pregnancies. They did not reach a primary outcome, and 3 of them had a primary outcome. 1, a fetal demise just past 10 days, and it was her 8th consecutive loss. 1 had preeclampsia at 33 weeks. 1 had preeclampsia at 30 weeks. These 2 babies and mothers are doing well. The babies are fine. So how does the study work, and why am I asking you to enroll patients? This map is where the patients come from, and we do have 1 patient from North Carolina. The way the patients come to us is you contact Dr. Branch, OB in Salt Lake City. You can see he's enrolled a lot of local patients, and we've enrolled a fair number in New York. You contact one of us, and then we do just about everything. We talk to the patient, we discuss the trial, we do a lot of preconceptual counseling around the trial. We then, as soon as the patient gets pregnant, they contact us. We do the screening lab tests, we check quantiferon, and so on. And if the patient meets criteria, obviously if they want to be in the study, but meets criteria, the drug is sent from a specialty pharmacy directly to the patients. All of these patients are on heparin and aspirin, so they know how to self-inject. So it's not as though that's an issue. And we collect data from the physicians, the OBs and rheumatologists who care for these patients. They're seen every month, which is standard of care. They have ultrasounds every month. We get the research bloods that are drawn in the clinic when they go for their routine care. The caring for physician is not an investigator and has low liability. The prescription is written by the investigators of impact. And our study coordinators speak to the patients generally every week or every 2 weeks. There's a screening questionnaire about any infections or any pregnancy complications or lupus flare or anything else. So our coordinators and Dr. Branch, as a kind of backup OB, the patients think they're their docs, but they're very compliant and they're very carefully watched. So what are the patients like who we've enrolled? 24 of the patients I'll show you data of. They have had really horrific pregnancy histories before. So about 20% of them, a fifth, have lupus. The others are primary APS patients. 80% of them have had fetal losses greater than 10 weeks. Some of them have had multiple losses because of preeclampsia or just intrauterine fetal deaths at 26 weeks, 28 weeks. I mean, really quite terrible stories. 33% of them have had HELP or preeclampsia. 54% of them have had growth-restricted babies, and 70% of them have had a thrombotic event in the past. So we're studying true APS patients who have had traumatic pregnancy histories, and anyone seeing them would say, wow, this is a phenomenally high-risk individual. The safety signal that the NIH and investigators were concerned about is giving a TNF inhibitor to a patient with lupus. Are you going to flare their, well, not even lupus, even primary APL, are you going to cause lupus in women who don't have lupus? Are you going to increase their APL titers so they'll get clots? Are you going to induce anti-DNA antibodies that are associated with renal disease? And only 2 of 19 patients, we haven't run all of the assays, converted from a negative to a 1+ DNA. No one had evidence of a lupus flare or new onset lupus activity. There were no substantial changes in the anticardiolipid antibody titers, no clots, and there were no serious adverse events attributable to the medication, and that would be infectious complications. So what are the results? Of the 26 patients, 23 have completed evaluable pregnancies. These are the 3 adverse outcomes I told you about. So what that leads to is a 13% observed primary outcome rate compared to a 44 expected. So we've only enrolled slightly over half the number of patients we need. We need 19 more patients. But I think these results are promising and hopeful, given how severely affected the patients are, and the expected outcome rate was dramatically higher. So I want to close by saying that treatments to prevent poor pregnancy outcome require an understanding of mechanism of injury. Our animal studies defined a novel mechanism of injury, and we're using that understanding to test a new treatment. I want to close by acknowledging my great gratitude, right? Profound gratitude to the PROMISSE and IMPACT patients. The PROMISSE patients, we spoke to them every month. They had lots of bloods. They were in touch with us. They never dropped out. They didn't miss appointments. The IMPACT patients are taking a risk. This is the first trial of a biologic in a pregnant woman. there's extensive experience of the safety of TNF blockers in pregnancy, particularly among IBD patients, but it's still a risk these patients are taking that might not benefit them, though it looks like it is benefiting them. The investigators, we had investigators both in the mouse studies. We had a big team in PROMISSE who I'm very grateful to. And all of our funders, we've been funded by foundations. Obviously, NIAN and Office of Research in Women's Health is our greatest funder. And UCB is providing medication for the trial, and an investigator-initiated grant. They don't own the data or control the trial in any way. They've been generous, though, with giving us drug. And finally, I think this is my most important slide. Memorize it, take pictures of it. If you have patients who might be eligible, who've had poor pregnancy outcomes, want to get pregnant again, or have had thrombosis, want to get pregnant, and they have a known repeatedly positive lupus anticoagulant, just call us. There's no work for you. We do everything. We talk to the patients. We can send them over the phone. And it has just, I think, been a positive experience for all of the impact patients. Even during COVID, they feel supported and they feel safe. So with that, I'll close, and thank you for your attention. And again, apologize for not being able to be physically with you. Stop sharing my screen.
Okay, thank you so much. That was just a beautiful talk from bench to bedside, and very, very clear. I can see there is Richard has a question for you, and I just want to remind everyone that if you make a note in the chat box, we will call on you and you can ask your questions. So we'll start with Richard, and I think council will unmute the individuals who want to ask a question.
Thanks, Jane. That was a terrific talk. I really had not understood preeclampsia before, and so your discussion of the spiral arteries and the remodeling was fantastic. That explained it really well. I had a question about the PROMISSE study results and the disparities that you observed. It's really interesting that it was education and economic status that seemed to make the difference. I was wondering if that was related at all to nutritional factors, because that's definitely been observed in people with particularly lower socioeconomic status, less access to healthy foods, and they might be eating more processed salty foods. So I didn't know if you had any nutritional data or any insight into that as a potential difference between the groups.
So I don't have nutritional data. The BMIs didn't explain the difference. I thought they might, but they didn't. And we're equally perplexed and challenged. I wonder, I mean, this is completely speculative, no data. I wonder whether the stress of living in a community where you don't have what you need can affect pregnancy outcome, because even though COVID was associated with stress, people stayed home and the stresses maybe were different, and there was much less preterm birth in COVID. So I don't know whether daily life in a dangerous community where there's violence, and whether that's studied that. I think there's a group that studied that in Atlanta, arguing that stress of safety affects hypertension. So I'm speculating. It's to me one of the greatest challenges. If we could understand that, we could impact we could impact national maternal health and fetal outcomes in the United States, which are quite poor.
I think that's a very good speculation. because there are data about the stress and how the impact that can have on various outcomes in lower SES. I wanted to follow up on that. I was intrigued by that as well, because what was interesting was the SES accounted for the differences in the people who did not have APL, without APL, but not with APL. There was still a difference in those individuals. And so, you know, what did you speculate? Were there different biomarkers, or are there things that go along with APL?
You know, I think the women with APL, first of all, there were really small numbers of women of color with APL. It's a disease that's much less prevalent in Blacks and Hispanics. So I don't think we have enough data to be confident. In addition to which, APL is such a profound risk factor. And if you add that to lupus, in terms of your vascular health, and we know that lupus is more severe in women of color, that combination may be what we're seeing. I don't know, I wish we had more numbers, but we can't create that. But I think if you look at the biggest population, the lupus issue, the racial issue, you know, we had a data safety, no, a DSMB, but it was really an OSMB for an observational study, just to make sure we were recruiting and keeping patients safe, because it was totally observational. And that was the most fascinating information to the OSMB. And we tried really hard to dig. And that's why we did all the census work. But we're like at a loss. If anyone has ideas, we can give you data to mine. We didn't have a strong disparities group, so Patty Katz's group at UCSF looked at all our data with us to help us.
That's great. We have another question from Onyi.
Hi, good morning, Dr. Salmon. Thank you for your talk.
Good morning.
I have a couple of questions. So the first is related to your mouse model of preeclampsia and the abnormal remodeling of the spiral arteries. When you injected antibodies from the APL patients, were they purified antibodies, or was it plasma or serum from these?
So, great question. So it was purified IgG.
Okay.
So it was polyclonal. But we did some experiments with lupus patients who had no APL, who just had like anti-DNA and all those kinds of antibodies, and that didn't affect pregnancy at all. Okay. So these were patients with lupus, but also primary APL patients. So the way we got our antibodies, these were really sick APL patients who had plasmapheresis.
Okay.
We got buckets of antibody, and buckets of serum, plasma, buckets of plasma, and we purified the IgG on a protein G column. So it's IgG, but it's not monoclonal, it's not specific, it's not antigen specific.
Okay. And then my second question for you was related to the mental health of a lot of these pregnant patients. As you had described, it's super traumatic to lose multiple pregnancies. So incorporated into your trial, are there, I guess, mechanisms for following up on the mental health of the patients that participate in both the observational and clinical trials?
If only we could do everything in hindsight. So we actually didn't collect those data, but I can tell you in IMPACT, where we are being much more meticulous because we talked to every patient, and in PROMISSE there were multiple sites. So the coordinators in Baltimore and the coordinators in Utah and the coordinators in Oklahoma were the ones who interfaced with the patients, not my coordinators. But now my coordinators are connected at the hip to every IMPACT patient. And one of the adverse outcomes, SAEs, you have to report to your DSMB is going to the hospital, going to the ER. And we've had 2 patients who go to the ER, who've gone to the ER with panic attacks at the anniversary of the loss of their previous pregnancy.
Wow.
So what you're talking about is so real. And nothing happened. They went home. They were calmed down and they went home. But it just gives you a sense of how frightened
Mhm.
these women are.
Wow.
Thank you.
Okay, well, we're coming up on our time. Does anyone else have a question? If not, thank you again for just a lovely, lovely, very clear presentation. We really, really do appreciate it.